Hello, my name is Dave Shahian. I'm the quality director for the Vascular Center at the Massachusetts General Hospital. And I'm delighted to be here today with Dr. Greg Walker of MGH Interventional Radiology. Dr. Walker and his associates have recently published a wonderful review article on the contemporary treatment of frostbite. This was published in the New England Journal, and I'm pleased to have Dr. Walker with us today to discuss this article. Greg, let me just start off by asking you, how did you get interested in this particular topic?
Well, I was very fortunate that we were able to collaborate with the burns services, particularly Dr. Rob Sheridan. You know, a little bit over a decade ago, we had the case of a young teenager who, after being involved in an unsupervised party, wandered off and was trapped in the snow, sustaining frostbite injury. And at the time, we really kind of had just a no standardized approach to frostbite. Dr. Sheridan called around to some of the medical centers in the United States in even colder climates than the Boston area that deal with this, particularly the University of Minnesota, and kind of was made aware of kind of a new treatment algorithm whereby catheter-directed thrombolysis using TPA was being used to try to restore flow to the thrombosed small digital arteries in the hands or feet. And so that was our first foray into that. And actually, this young patient did tremendously well. There was frostbite involving both hands and one foot. He suffered no amputations. An extensive rehabilitation period followed after tissue debridements, etc. But we were able to save all digits, and the older treatments of frostbite really didn't have nearly those great results. So that really piqued our interest into kind of investigating this. And over the years since then, I've been fortunate to collaborate with the burns service with several surgeons, and we put together an algorithm that's in place now at MGH for the optimal treatment of frostbite. And based on that, publication of kind of a review article ensued in the New England Journal.
It's extremely interesting, Dr. Walker, on the early origins of your interest in this. Is this phenomenon of frostbite, this kind of injury, is this just extraordinarily rare, or is this something that still happens frequently enough that many hospitals are going to see this, particularly in colder environments?
Right. Well, of course, as you alluded to, it's tremendously weather dependent. Living in the cold winter climate of New England, we actually do see it with some frequency. We may see one year I can remember as many as a dozen cases, some years with milder winters, fewer cases in the range of 4 to 6. Unfortunately, in Boston and in other cold climates with so much homelessness, that's a particularly vulnerable population of individuals who don't have warm shelter necessarily during the terrible dips in temperatures. And so we'll often see spikes around a sub-zero weekend or weeknight sort of thing, and sometimes can have as many as 2 or 3 patients who come through the emergency department or evaluated first by the burns service, if deemed appropriate, sent to us for thrombolytic therapy. So unfortunately, it is reasonably common and certainly common in these at-risk populations.
Is this the kind of injury that generally should be referred to a major center that has interventional radiology and other advanced capabilities?
Yeah, I think it is. You know, I'm not certain, and hopefully this review article will help with that. I'm not certain that all hospitals know about the efficacy of thrombolytic therapy. We do this as a catheter-directed intra-arterial thrombolytic therapy administration when indicated. But you know, if a community hospital were to see this, they could start systemic TPA, a systemic thrombolytic dose, presuming there are no contraindications, head injury, or recent surgery, that sort of thing that could result in a hemorrhagic complication. But something such as that could certainly buy time as a patient was referred to a major medical center for additional treatment. And obviously the other adjuncts such as, tepid rewarming of the extremities, making sure that the core body temperature is appropriate, administering resuscitative measures as needed, because it is a systemic disease, not only the extremities, of course, but when the core body temperature plunges, then there are all the other considerations that require the discipline of kind of a multidisciplinary approach. I think that's one of our strengths, is that we work with other specialties. We have an informed physician and associated practitioners population that can allow us to achieve these good outcomes.
So I think you're starting to touch on an area that I'm interested in hearing more about. What is the actual mechanism of injury in severe frostbite? Can you talk about that a little bit?
Yeah, absolutely. So with regard to the extremities, which is kind of where my group becomes tremendously involved, it's crystallization of the tissue fluid in the soft tissues. And that can be dealt with through slow rewarming of the extremities. Also, people can administer crystalloid that has been warmed to help with the core body temperature. But what it doesn't address with the rewarming is the fact that the small vessels of the digital arteries, for example, in the fingers and the toes, and even sometimes in the palm of the hand or in the ankle, those thrombose because of the freezing injury. And just rewarming, of course, doesn't do really anything to alleviate or eliminate the thrombotic process that's occurred in these arteries. People in the past have tried various things, anticoagulation, not really very effective, administering agents to increase or decrease sympathetic tone, etc. But it really wasn't until finding out that we had a mechanism for dissolving thrombus quickly in the digits that we were able to preserve and prevent amputation.
And I know in your article you mentioned the use of vasodilators. Could you touch on that a little bit?
Yeah, so typically the cold not only produces thrombosis, but also vasoconstriction with the body's attempt to kind of redirect blood to vital organs. And so we do, during the initial angiography, when we're evaluating to determine if indeed there are thrombosed vessels, we administer vasodilators, assuming that the vitals are stable and can withstand, the effects of nitroglycerin. We administer those to get maximal vasodilatation. We administer the thrombolytic agent. And I will say that the burn service has been great about selecting out appropriate patients. We can do things such as Doppler ultrasound of the digital arteries to be certain that they are thrombosed. So we're not taking patients and unnecessarily exposing them to an invasive procedure like an arteriogram. So that's kind of part of our algorithm is, who's appropriate for this? How long do we administer the thrombolytic agent and the vasodilators? Because it turns out that you get fairly rapid dissolution in the first 24 hours, but we've extended thrombolytic therapy to as long as 72 hours in some patients with gradually improving results in terms of digital preservation.
And I would assume that for all these frostbite treatments, that the quicker you institute treatment, the better the results going to be. Is that?
Absolutely. That's very fair to say.
Well, Dr. Walker, thank you so much to you and your colleagues on the burn service for all that you have done to advance the science of the treatment of frostbite, and for being a regional resource for these patients. And again, we thank you very much.
Thank you. Thanks very much. Yeah, it's been very rewarding to be a part of something that has really blossomed from kind of an isolated case to something that kind of is now an algorithm and a mainstay of treatment with, we believe, very remarkable results.
Great. Well, thank you again, Dr. Walker.